We are thrilled to have a great lineup of speakers for you today and to be having this event in partnership with the Global Health Center, which is also situated and hosted in the Graduate Institute in Geneva. The key part of this work that relates to our strategy is really thinking about how does equitable and quality education overlay and intersect with other SDGs. Could you move the slide on, please, Daniela? So these are the 4 themes that we have in our strategy. And one more, please, Daniela. And this particular webinar today is saying, yes, the SDGs acknowledge the importance of these interconnections between different issue areas and different sectors that have traditionally been considered to be separate domains of expertise and practice. And in response to this, intersectoral collaboration has come to be seen as a more efficient and effective way of working. And the title of this webinar today has a question mark behind that to make sure that we're asking the question and we're not just assuming. If you could go one more, please, Daniela. Just one more forward. There it is. And this particular webinar today is looking specifically at the intersection between education, SDG 4, and health, SDG 3, and then asking certain questions about intersectoriality as a desired practice. And Daniela will put the link for our strategy into the chat. Thank you. And the other recent piece of work that we did in this same strategy about intersectoriality and health was the NORRAG special issue on states of emergency education in the time of COVID-19. And again, Daniela will put that into the chat. And I will hand over now to Tamam Aloudat, to say hello from the Global Health Center before we then move back to introductions of our presenters. Tamam.
Thank you very much for the introduction, Mara, and thank you everybody for joining us. It is a pleasure to be having this conversation and to host our esteemed speakers. The Global Health Center has committed from before COVID even to addressing issues of global health, to an open global health. And that means transparent and capable of discussing issues that are restricting people's access to health, but also people's participation in determining their own. And this education is the one, if we talk about intersectionality, the education is one of the immediate ones that do make a huge difference. It has always been known in health sector that education is one of the most present and effective determinants of health outcomes. We are happy to have this conversation and happy to look in the time where COVID has both proven a massive potential for policymaking on global health and education, but also a massive gap in our way towards achieving equity, those conversations can happen and we can hopefully go forward with a better understanding of how to work together. Thank you very much for being with us, and we look forward for a rich session. Thank you.
Thank you very much, Tamam. An absolute pleasure to be working together with the Global Health Center on this. And the first part of our agenda today is a presentation from Paul Kearney, who is Professor of Politics and Public Policy. And he is going to present part of his article that was co-authored with Sean Kippen, The Future of Education Equity Policy in a COVID-19 World. Paul, thank you very much for being with us today. We look forward to seeing your presentation.
Thank you. Right, let's see if I can share it successfully. Okay, how's that?
Perfect,
Okay.
We can see it fine.
Okay, good. Let's see if I can skip through. All right, so. Okay, so here's the context for the kinds of discussion and reviews we do. So this is so I'm part of a team that looks into policy processes more generally, and here are the things we tend to find when we look at equity policies or so-called preventive or early intervention type policies. So the first thing that happens is many people, politicians, policymakers, make some kind of vague commitment to equity without really defining it, or they're looking to reduce unfair inequalities, and they don't always say what is fair and what is unfair. Then they talk about equity policy making, and you can take your pick on the phrases they might use. So intersectoral action is one, but people often talk about holistic policy making, or joining up sectors, or collaborative governance, or whole of government approaches, and so on. And then what we tend to find is that they report limited progress. And some policymakers become disenchanted with their lack of progress. Some people who work in sectors for much longer develop a sense of stoicism. They know the language of equity and policy making, and over time they're less and less confident it will happen. But it makes sense to continue to strive and use that kind of language. And increasingly, some people in some sectors are now seeking lessons from studies of policy making to find out how those kind of insights can help them engage more effectively, for example. So they're looking, so we are looking in a series of reviews to ask, how are they using insights from policy studies? What purpose do they seek from these insights? And how will they find what they're looking for in these kind of policy studies? That's mostly what we're interested in. And if you're looking for the punchline, I think often the answer is no, they won't find. So we've started a series of reviews of equity policy and policy making, starting with health and then education. And if we're making this comparison between your health equity and education equity policies and the use of policy insights, they seem to have the same very general aims if you're looking at them in the abstract. Okay, so both are looking for some kind of engagement with equity policy, and they describe it in terms of unfair inequalities. Both sectors or researchers in each sector are looking to foster intersectoral action by contributing to some kind of broader goal. So, the obvious one would be their contribution to the SDGs. And then they're looking to use policy theory insights to help. So in that sense, they're quite similar. But then there are also these key differences in practice. So the first relates to what happens when they identify a gap between these three things. So one is they choose to contribute to other people's intersectoral action. They choose to contribute to other sectors, but they also need others to contribute to their agendas. And that is when you find this gap between what they need to happen then and what they expect to happen. There's this gap between essentially their functional requirements. They require people to work together to fulfill their aims, but they don't necessarily expect it to happen. And that leads on to different expectations within these sectors and a different use of policy studies that reflects that different expectation. So this is one that I'll come back to at least once. If you're in my kind of field studying policymaking, I don't think you really expect intersectoral action. You expect to find the language, you expect to find the intention, but you don't expect to see much progress. Now, I think that can be different in areas like health. There does seem to be a sincere expectation that intersectoral action is possible and it will produce some kind of change. So that's interesting. So I think if they're looking for insights from policy studies, they'll often be disappointed because they're not finding ways to do it. They're finding explanations for why it doesn't happen. But probably the third more interesting thing is that, perhaps ironically, there are sectoral approaches to intersectoral action. Each sector has its own way of thinking about it, and they don't necessarily agree on what intersectoral action is between different sectors. Okay, so I'll describe that in more depth after introducing both health and education. So health equity, it tends to be associated with, a global agenda taken forward by the WHO called Health in All Policies. And it starts off by saying health is a human right to be enjoyed by everyone. Then it says that, the population health is socially determined, or there are social determinants of health inequalities. They're not caused by individual choices or lifestyles. They're caused by much more population-wide differences, such as differences in power, differences in income, education, and more or less access to safe social and physical environments. And so then they say, what we need to do is identify evidence-based solutions that are upstream. They're not individualists. They are very much focused on the ecology or the environment that surrounds people. And you can see intersectoral action is at the heart then of that agenda, partly out of necessity, because they would say almost everything to do to improve health is not in the gift of health departments. If this is about unequal income or education or housing or social physical environments, it's not really about healthcare or health sectors, it's about everyone else. So then we use this phrase, the health and all policies playbook that people try to use to foster intersectoral action. So the classic one is this idea of a win-win strategy, show other sectors why they would benefit from benefiting a health strategy. And then almost inevitably, a lot of these articles end by identifying an implementation gap and being dispirited about it. Okay. Now in education, I think things are quite different. I described, a single health and all policies approach. In education, if you look at, the comparable research literature, there is no single approach to education equity. There are two competing approaches. I think they tend to be described. Now, I should say, almost all of the articles that we reviewed come from researchers who I think would put themselves in the social justice bracket, and they would see people fostering a neoliberal approach as the villains of the piece, and I don't think they hide that. It's not a particular secret I've unearthed here. So these are neoliberal versus social justice approaches. Then how you define equity. So I often forget which one is which, but horizontal was essentially giving everyone the same access to something like schools. So equity is access to some high quality resource, whereas vertical equity is an unequal distribution of resources to try to produce more equal outcomes. So it might be more support so someone can reach a similar outcome. And then there's a competition in terms of different approaches on policymaking. So the neoliberal approach would be associated with treating education as contributing to economic growth and using new public management techniques to help schools, make schools compete with each other or make education systems compete with each other. And that would be seen as in contrast with something more inclusive, where education is something for emancipation and the focus is on capabilities or out of school factors. The second difference is that it's very much more focused on schools. So I think particularly if you're from organizations like OECD, you would say a lot of the power to do something about education equity comes from education systems and school systems, which is very different from the kind of health approach. And it's much more of a focus on phrases like minoritization and marginalization, where people are identifying the impact of race and racism or gender and sexism on unequal outcomes within schools. And there's much less of a focus on the idea that you can identify implementation gaps from the top down, much more focus on bottom-up approaches and seeing schools or school leadership or something like that as a legitimate place, whereas often in health, any kind of major differences across localities are often seen as departing from the plan. Okay. So you can see these sectoral approaches to intersectoral action are then reflected in the use of policy studies. So in public health, they use these policy theories quite instrumentally. So essentially, and they use this, it's the same with public administration type studies. So they're looking for high level political support to overcome barriers to intersectoral action. They're using policy theories to help close gaps in their program logic. Now, I think maybe in other sectors, program logic would be called, theory of change or something like that. So they're trying to update their theory of change. And they're looking for practical lessons for advocacy, to help frame things better, to form coalitions and such like. An interesting aside is that in most of these studies, they essentially externalize the idea of neoliberalism. We have a very, coherent internal narrative about health and health policies. And then they say, okay, there is these implementation gaps, often caused by neoliberal approaches taken somewhere else outside of health. Whereas in education, you have a much more reflective use of policy studies and a focus on critical policy analysis. There's this internalization of neoliberalism to sort of explore that tension between approaches. And there's much more of a focus on multi-level dynamics, focus on bottom-up type policy making. Okay, so finally, before we move on to more discussion, these common themes or different themes you might find in health education, they also connect to different themes you might find in policy studies. And I think one question that I ask myself is, if you're looking for instrumental lessons from policy studies, would you actually want the lessons that policy studies tend to provide? Okay, so the two examples here. One is that I think there's a distinction between an unwillingness to join up policy and the inability to do so. So I think, particularly in health, people focus on the unwillingness to do this, the lack of political will to overcome boundaries. But I think in policy studies, you would say there's a very strong logic to silos and to sectors, to specialization that is not really acknowledged in these intersectoral type approaches. An interesting other aspect is this idea of governance dilemmas. So what happens, for example, in particular with health, but not so much with education, is that you find highly centralist approaches. So essentially it's about coming up with a high-level strategic plan, making sure it's carried out in most localities, because you need that kind of uniformity to reduce inequalities. But at the same time, the same people want localism. They want people to collaborate at local levels, come up with their own language, think about things. And they want both of those at the same time, without really acknowledging that there's a trade-off between centralism and localism. There's a similar trade-off with so-called evidence-based policymaking, again, particularly favored in health, and collaborative governance favored in both approaches. And I think one of the trade-offs is if you take a kind of public health-based, evidence-based approach, this is often about things like randomized controlled trials or highly methods-based knowledge that has primacy over other forms of knowledge. But in collaborative governance, you reject that idea, and you say everyone has legitimate claims to knowledge. And those two things really kind of butt up against each other. Again, people want both of those things. They want evidence-based policy from particular methods, and they want to acknowledge a lot of different knowledge claims, but without really knowing how to put those together. So those are the kind of dilemmas you would face with intersectoral action that I think policy studies would focus on more, rather than trying to find a kind of series of technical problems. Okay, thank you for now.
Thank you very much, Paul. And as you can see there, Paul has a blog which has lots of very useful information and policy studies in 1,000 words and in 500 words that are very, very handy for people who are looking for introductions to and deeper treatments of policy, policy analysis as well. So thank you very much for those provocative thoughts. And what we're going to do now is turn over to our two discussants. So we have first Colette Chabot, who's at the International Education Program at George Washington University in the USA, followed by Remco van der Pas, who's Senior Research Fellow and Lecturer in Global Health Policy at the Institute of Tropical Medicine in Antwerp, Belgium. I introduce you both now so we don't have to go back to the slides again. And we'll start with Colette, please.
Thank you, Moira. And thank you to NORRAG for inviting me to participate in this webinar. I really appreciated the chance to get to know your work and the work of Paul and the work in network strategy and policy strategies better. My work, as you know, really focuses in a little different area. It looks at the role of organizations and organizational fields in carrying common policies around the world. And so a lot of what I'll be talking about does refer back to organizational theory and organizational literature. My own work has looked at how Education for All, the 1990 conference, which really focused on making the education human right a greater reality, came out of and was inspired by a subset of Health for All, which was a 1978 initiative, big conference for which was led by WHO. And when I first saw Paul's paper, I was actually a little confused, and I thought, where did Health in All come from? It didn't take me long to find it, but I would say that that there are great parallels, and I liked Paul's idea about these the difference between horizontal and vertical policies. In sociology, we would talk about structure and an agency, and we would also talk about these ideas about whether you should have a comprehensive approach or a more opportunistic selective approach. And I think WHO, both in Health for All and in Health in All, are very much of a comprehensive, as Paul has said, a top-down approach. And I think that is, it's very interesting that some of the same frustrations that people had with Health for All and some of the more selective approaches that came out of it, such as the Child Survival Initiative, have some of the same problems, have some of the same tensions around them, it's a much more rational approach. It's the comprehensive approach is what we would all like to do, given enough money, but the funding is limited. I would take issue with Paul's title. I don't think there is the solution to anything. I've recently been enjoying Kim Stanley Robinson's novel, The Ministry for the Future, which talks about actually how we might 40, 50 years from now be able to address climate change. And it's about a very fragmented approach. It's about an approach that has a million points of light in different groups, from terrorists to World Bank-like institutions to scientists at the Arctic. So I think that this tension between whether we're going to get a comprehensive solution that's going to involve everybody doing things together, or whether there's going to be more selective stuff, is a big issue. Inequity as well. I was interested, I loved your summary of the paper, and I'd like to get your slides. I read your paper, the full thing. And I got to the point about the section called The Limits to Processing Information. And this whole idea of why policies, turn out to be less than rational. And in my work, we talk a lot about what you do when there isn't sufficient information, when there isn't sufficient scientific data to make decisions. How do you go about making decisions? And I draw on some very old work by DiMaggio and Powell about institutional theory, looking at in the absence of clear output information, one either copies what you think the best guys are doing, you form little professional groups and you decide what best practice is, and you support each other in public places to say, yes, this is the best way, or you end up with the people with the funding deciding what gets done. And so I would it would be interesting to see how that would apply to this section on these limits to processing information. I would say it's more the limits to what to do when there isn't enough information. And that's certainly what we face in education most of the time. I am, of course, in your conclusions, I don't know how much time I have, Moira, and I'll try not to take up too much. How am I doing? I got 2 more minutes. Oh, I better get to the conclusions then. The
You can take longer if you need it, Colette. Please don't rush.
In terms of the post-COVID, you know, my theory, which talks about this spread of the diffusion of institutions around the world, whether they're policy or whether they're ways of organizing. Conventional graded schools where all the kids get together in one building, separated by age groups. It has not been functional for lots of people, and yet we keep going back to it. We find a very hard road, anything that is going to be not conventional schools. And that's going to be an uphill battle. I wrote a piece for UNESCO talking about this being, you know, there's no fail-safe here. All we have is conventional schooling, and when there's an emergency, it doesn't work. And there are always emergencies. I've worked in emergency education for years. It's very clear. It's just a matter of time till, you know, we have our earthquake in California and those schools, you know, are not going to work. And we had our pandemic, but it's very hard to move away from that global model. The second one is this structural systemic change seems to be beyond the reach of most policy institutions. And we want it because of Western rationality. We want, you know, it to all line up nice and neatly and plan it in advance and have it supported by, you know, RCTs and Western scientific data. And wouldn't this be nice? And in fact, in practice, I don't find a whole lot of places where anybody's been able to do this very well, apart from, you know, one looks longingly sometimes at some smaller European countries that are certainly a lot more rational than the United States. We also have the problem that a lot of education research was produced by, if you look at even your section on the amount of education research produced by Americans who have a cultural predisposition to agency over structure, and whose system also supports that. So it supports a lots of individual initiatives, and not so much going to change the whole system. We didn't even have a National Department of Education for a long time. Many people around the world, many researchers around the world also trained in the US. So that disposition towards saying that structure is not going to work and we're going to focus on doing these bottom-up sort of things, I think may have something to do with what gets researched, and what we tend toward. Finally, I love the insight that education policymakers don't have a common strategic vision or playbook. Oh, they certainly do not. And part of this we'll talk about in the next section is this lack of scientific base. And I think that WHO has been slightly more effective than UNESCO in uniting people around some sort of a scientific consensus. We haven't got it. And I think I'll stop there.
That's great. Thank you very much, Colette. And now we'll hand over to Remco, who is a doctor as well as a researcher. Remco.
Thank you. And good to be in this community. It's a bit of a new community also. And so that's how we make the intersectoral links that matters. So it's very interesting to hear about the let's say the equity approaches in education, how to analyze it and what works and what doesn't work. So my background is that I come from this Help for All movement. I work for NGOs, been affiliated with the more like the People's Health Movement initiatives that built forward on the Alma Ata Declaration on Help for All, and was then also involved in the let's say in the background developments of on the social determinants of health work that WHO was doing about 15 years ago. And so that's one point that I would like to make clear. There is a lot of theory and strategy and concepts on health and on policies and how to attain equity in health. It's not that we're lacking the concepts and the theory, it's about how it's getting implemented. So you read a lot of papers about this is how it should be done, while the real question is, well, but how is global health, and why is there such a gap between this theory and the actual implementation? And that's where part of my policy analysis work is also situated. I do quite a lot of work on health workforce development and health work. So why is it that the health workforce seems to be somewhat neglected when developing health systems, and how can they be involved in relation to equity? So two things in remark to what has been said before. The question is indeed, so everyone talks about intersectoral and interdisciplinary approaches, but we still find ourselves in this bubble. Also I find it quite strongly within the healthcare sector, although me and many colleagues realize that health outcomes are being generated, equity is being generated outside the healthcare sector. Still, a lot of our program is focused on health care itself and the services that are provided, and we look at it through that angle, which in a sense causes, it's a kind of we are myopic, I think, in the sense that we do realize that there is a lot of gains to be made while working, for instance, already with people who are working on secondary education, university education, in health workforce development, post-career development, etc., and how it fits with career development and decent jobs. But I think it's because of structure. This is where Colette, I think, when your intervention comes in, a lot of the initiatives being funded in global health are quite targeted and specific. They have quite immediate effects, but the more upstream determinants are not being addressed in that regard. And for me, one of the main frustrations I still have with workforce development is there's so much focused on education, on performance, on quality, but there's much less focus on the actual jobs, the decent jobs that are required to finance a strong health workforce. And this is where the whole, let's say, fiscal space policy comes in, financial decisions are coming in, and how that is being approached in a coherent manner between sectors. And this is where a more political economy understanding of is required, and how power and conflicts of interest work, why a lot of interventions that make sense have not been conducted. Now, I do think that when I hear a little bit about and when I see it also with students and being involved in university teaching, the education field has been more of a market niche than the global health field was. There was simply, especially before the 90s, before the fall of the world, there was simply not too much financial demand for health. But over the years, you see this is growing rapidly. And that also then disinhibits, let's say, the more common good approach vis-a-vis this more liberal economic development focus on universal health coverage, where there's a lot of focus on expanding coverage, but which might have an impact on quality, but it doesn't really address, so it's a lot about care, but much less about prevention and treatment. This is something that we see. Now, one thing that amazes me also with the COVID-19 response is so much of the approach is on vaccine development, while a lot of public health measures that we can take are could be taken outside the more biomedical field, and it's in relation to old all long-known public health principles of lockdown, on quarantine, on isolation, on managing the public sphere in a way that it reduces risks, but due to demographic changes and also a lot of demand in middle income settings, etc., there is this focus to individualize the healthcare sector more, and I think this is where we can learn from education how to mitigate it, I would say. So I would just see that global health follows a little bit later after what's happening in education. Now, one thing you were reflecting also on, it's a little bit, I mean, as a medical doctor, we adhere to the Hippocratic Oath. So there is a kind of an understanding, and so we've not been trained for that as well in the medical field, that this common good, let's say cosmopolitan human rights approach, and that's inherent to our work. So I find that quite some of my colleagues are a little bit blind to those forces, let's say in the field of the securitization of health that we now see with all the countries pursuing their national security interests by hoarding vaccines, etc., or the more economic drivers that are there to invest in certain healthcare practices over other. This relative blindness that we have, I think maybe we can also, it's good to have I would be very interesting to set up a workshop between teachers and healthcare workers and to exchange on policy issues that they can influence or not, and whether that works across whether there are lessons learned between the sectors that we can aim for, and also indeed to what you aim to do, to have a kind of an intersectoral analysis of it that makes sense. But I would argue for more to follow it up with really empirical studies, with case studies, so that it would that you get to have a good let's say focus group discussion involving teachers and healthcare workers about a certain topic or a policy proposal by the government. That will be very interesting. Much more to say, but I will keep it from here.
Fantastic, Remke. Thank you very much. And so before we go to the audience Q&A, we are going to have a roundtable discussion with Colette, Remke and Paul, and we have 3 questions that we would like to ask them. And we are going to start with the first question, which is basically coming back first of all to you, Remke. What is it, do you think, that health envies about education? And then for Colette, what does education envy about health?
Let me think about it. Would you like to start, Colette? What does health envy about education? I think what health envies about education is that it's, and so I'm looking a little bit at myself here, being working both in the education field and in the health, and being a healthcare professional originally. I think in the education field you have initially more autonomy to shape the content of your courses and how you work with students and pupils, and to shape the narrative, I would say, and to work with them, and maybe to bend a little bit around existing, let's say, protocols or curricula, etc. At least I feel that I have quite some space to do that, as long as they perform in the end. But I can talk with them whatever I want. And in healthcare, there's a lot of supply in healthcare clinics. The healthcare workers don't have the time often to create an initiative where they would work beyond the demand of the day and beyond the actual needs that are there, because they just getting tired by seeing all those patients coming through them in a primary healthcare practice or an emergency ward. So I think this is what is being envied.
Thank you. And Colette, the other way around. I think you're still on mute.
I meant at the beginning also to thank Gita Steiner-Kamsi for inviting me to be on this panel. She edited a book that I wrote specifically comparing Health for All and the Rise of Education for All, and these comprehensive and selective approaches and how they survived in education and health. So I spent a lot of time interviewing particularly tropical medicine researchers. And so I would say that what they told me was that they really envied education for all of its cute, photogenic, heartwarming school children, instead of having to talk about diarrheal disease and malnutrition. And they said, this is much easier to raise money about this. And this is something we have to keep coming back to, getting back to what I said about when you don't have data, scientific data, what makes the decisions? And often it's what the funders are willing to fund. And can you grab their heartstrings? And so they expressed to me how much they envied our pictures. And in fact, the transition from Health for All, a comprehensive approach, to child survival was really started working with pictures like I have on the cover of this book, which is starting to use cute little children to advertise child survival. You know, babies, hey, for a few pennies, you can make this child live. And, you know, they made a big deal out of that. Medicine also, they told me, seems foreign and threatening to many people, but most people feel like they have some grasp of the importance of schooling and some warm, fuzzy feelings about it. And everybody believes education is the key to equity. The health people as well express this. And schools are great delivery sites for health interventions. So they'd love to have some place they could capture people as well as we capture all these children at school. But as an education researcher and practitioner, there's a much longer list of things we envy from the health people. And starting out with that lovely authoritative science you have, and all those numbers and those universal interventions, or pretty much universal. They're not as universal as we sometimes think. And those nice dosage information, which means that you can say, with this much, you can get this much result out of this person, and you get funding as a result. And that is why Health for All, the comprehensive approach, broke down, because they could not put a price tag on anything. But you can put a price tag on a vaccine. You can put a price tag on a malaria intervention. And that leaves the healthcare workers completely to one side, just turns them into delivery agents, as you were saying, that don't have this sort of ability to tailor what they're doing the way they would like. But hey, it works. And once it works, you know, then we end up with Gavi, we end up with all of these other single intervention things, which we now know how to do, but we don't know how to do comprehensive. But health has got this authoritative science to do this. We used to think they couldn't push back, though that COVID has given us a great example that sometimes people do push back on health, and they say, I don't believe in masks, and I don't like that particular vaccine, and I don't care what science says about it. So it's not infallible. I don't think you know, Remco, or I'm surprised you don't know, but much tropical medicine research was supported by the expansion of Western Empire and the need to keep troops healthy. So there are few, if any, and so that's where we got yellow fever vaccines. That's where we got ORS. We got oral rehydration out of the search for something that would treat cholera. There are few any military applications for education, and therefore none of the sort of massive military funding, which, believe it or not, has less strings attached than most other funding. And health health researchers in many cases were able to be a lot more inventive. They were placed in the field for years at a time, and they got a long ways. Health research has produced, we also envy the fact that health research has produced lots of innovations with quantifiably measurable results. We've experimented recently with something like early grade reading. We've gotten as much pushback as you can imagine for being narrow-minded and terrible and don't you know we need a comprehensive approach? And I said, yes, we need a comprehensive approach. Of course we do, but we can't implement it and we don't have it and we can't raise money for it. We can get money for that. And it may lead, and it led to then more funding for early math as well. God willing, it will provide more money eventually to go up to grade 8 with some of this stuff. So, you know, we have used health as an inspiration, and some of our education colleagues hate us for it, for trying to see if some selective approaches might move the equity along faster. The time frame for measurable results in health is much shorter. So in education, it takes a very long time to prove that you've actually taught this child something and that it's sustainable and they will use it in life. And that again gets back to what can we measure earlier, and leads to things like reading and math. And finally, the education interventions, as I've mentioned, they lack universal formula or dosage and can't be associated with a price tag, which you can present to those funders that don't have enough data about comprehensive or doing anything else, who might just decide, I'm going to do it. Those are the things I could think of.
Thank you, Colette. We are going to go to Sarah Beardmore now to ask a very interesting question that has come up in the chat, and then we'll come back again to more roundtable. Sarah.
Thanks, Moira, and thanks to all of the speakers. I think this is such an important conversation to have. And what I was curious about is whether there are any examples of positive deviance where intersectoral collaboration between health and education has actually been successful, and perhaps an appreciative inquiry we could learn from. You know, what were the budget arrangements, governance mechanisms, how was collaboration structured? You know, what were the elements about it that made it work that we might, you know, be able to learn from and potentially try to cultivate in terms of providing enabling conditions for better sectoral collaboration. So thanks.
Thank you, Sarah. Colette, you had an enthusiastic response to that?
There have been a bunch of selective interventions at the early childhood and schooling levels between health and education. So early on, even as part of child survival, they started pushing female education because they said this would help future mothers to be better mothers and also deal better with maternal health. But we've got a bunch of other examples as well, with nutrition, with mental health, on bullying. In fact, child-friendly schools started out as a WHO initiative to improve mental health and bullying issues in school, gender identity, endemic disease treatment. Oh my goodness, in the 2/3 world, there are many different simple selective interventions that can be done at the school level. We haven't done as well at higher education. We haven't done as well in adult continuing education. It's, again, the school tends to be privileged, and that's where I've seen some of the intersectoral work. But the intersectoral work that I've seen that we actually have measurable results for is all selective. It's not comprehensive approaches that I can think of anyway. Can you think of any, Remco?
No, I think it's also rather selective indeed. What has overtaken, I'm thinking a little bit about the medical education, where I'm thinking a bit about. I have two things that I would like to reflect on. First, the medical education, where in Western Europe, so I'm teaching in the Netherlands and Belgium. What is it? A problem-based learning, which was a little bit piloted in the medical education field, together with educational scholars and professionals that they have been tinkering and working together to, let's say, restructure curricula so that it's more focused on actual problem solving than delivering theory. And this is where, at least in the Netherlands, medicine played a role, where there was also a recognition that it should be much more, let's say, oriented towards the real problems that people have, rather than a expert, let's say, understanding of a disease by a medical doctor. So I think there has been a lot of like in Maastricht, where I am, the School of Health Professions, it's seen as one of those early ones working on health promotion and teaching and to develop that jointly. But indeed, over the years, it's not that there is so much financing going into that vis-a-vis other selective interventions. And secondly, and that's more at the primary care level, and I'm coming from this Health for All movement, there was in the late 70s, early 80s, this whole movement working on where there is no doctors, working on the principles of Paulo Freire. They've been quite warmly embraced also by the health community at that time. Also with the understanding that quite good health could be generated without having medical professionals or a lot of more, let's say, secondary drugs available, that with limited tools you could already generate good health, and that working via community education and on rehydration, etc., and nutrition, that will be a good example to do so. And especially in the Latin Americas, where also this book, where there was no doctor, in Mexico and the Cuban experience, etc., also work in Bangladesh around that time after independence. So there have been real examples, but they seem to have been forgotten a little bit in scaling up and in the more specialized approaches that have been developed over the last decades.
Yeah, I think too, there is within the health community and some communities an appreciation that for the Sustainable Development Goals, without SDG 4.7, which doesn't have good indicators right now, which means it could be dead in the water, because the indicators tend to drive the attention and the funding. Without getting the hearts and minds of children engaged, it's not going to happen in the long run. So I think they're still looking for ways to engage with that. And SDG 4.7 covers gender equity, it covers sustainable development, it covers global citizenship, it covers all of these things, which have a lot of health implications as well. So, but that's a real struggle. So the group that I'm working with mainly at the moment, called NISM, and I won't explain what that acronym stands for, is focusing on trying to get more SDG 4.7 and social and emotional learning into schools, because there must be that social and emotional connection. And I see the social and emotional side being very much tied to mental health and to some of the, again, the same things WHO was talking about with child-friendly schools.
Fantastic, thank you. Right, our next question then is let's start with Paul this time. And after this question, we will go to the audience Q&A. So please do write your questions in the chat box. We've got a great array and diversity of questions and comments there already. Do please add so that we're ready to take those, for our speakers to take those questions after this question from me. So for Paul, what for you are the opportunities and challenges to intersectoral research, practice and policy? What is it in your professional life that looks challenging or would benefit from?
I think, yeah, I mean, I suppose I think I tend to be a strong source of challenges rather than opportunities. I think, I tend to be able to explain failure rather than, aid success. So, I mean, I think I talked about some of the challenges in terms of, silos making sense and not really agreeing on what kinds of knowledge would inform these collaborations and, what should be the appropriate level of government, that sort of thing. And probably the only challenge I didn't talk about much was this idea that when people engage in intersectoral action and collaboration, they essentially give up control of, what would you call it? You give up control of the research question or the how to define policy aims, or even the words you can give to certain things. So this does come up with health and all policies where some people say, okay, well, some people don't like the word health, so they prefer well-being or social justice or something like that. And I think the challenge is, I think people are willing to go along with that, but also think that their work in, say, health is diluted. They can't recognize it anymore. I think there's some of those challenges about how enthusiastic people are in practice. In terms of opportunities, well, I tend to struggle, but I think there's still untapped potential in studies of collaboration. And work sort of by say Eleanor Ostrom and colleagues on how to manage resources. I think there's a lot of that kind of work that is sitting there that could be used if people invested the time in understanding it. There are some approaches that are quick wins. You can study public administration, you come up with 5 tips for joined up government or something like that. Whereas Ostrom-like work is a bit more like an investment in you've got to take a course really to understand it. So I think there's opportunities, but they're not superficially available. They require a lot of work.
Thank you, Paul. Remco, what for you in your work are the opportunities and the challenges?
The opportunities and the challenges for bringing these together. So challenges, I think let me start with that. It has to do with time and specialization. The health field has become a very specialized field. The way we work in health and to go through the career ladder and what's being valued is that you have specific knowledge over, let's say that you capture knowledge that is only scarcely available, and that you be the expert in that. And a lot of healthcare actually works because there is, let's say, a knowledge gap between those with expertise, medical doctors, and patients. Otherwise, you don't need to go to a medical doctor because you would already have the knowledge. And that implies that a lot of our training is rather specialized, and that we lack the horizontal approach in understanding complexity. And there was a reference to OSOM, etc. We tend to, there is a difficulty for many professionals to see the different aspects in a person's life, including education, that frames health outcomes. I think, for instance, WHO starts to see that now more as well, and there is some more with COVID and other complex challenges that we have. There is more understanding. There's now the WHO Academy being established in Lyon for that purpose. So there is a challenge on one hand that we are being forced in the biomedical world to specialize and to also to then do research on quite specific interventions. The opportunities that are there is that people, like Colette also mentioned now, see with COVID-19 that this evidence-based, rather narrow solutions do not necessarily address the problems. And I'm thinking also about climate change, for instance, and the impact on health, and that is something really we need to engage in as health professionals. And I think in the educational field that's being done much earlier already. And so there are opportunities there, because I see a younger generation, I'm reflecting a little bit about my students as well, that realize that the more, let's say, narrow biomedical way that they have been trained in over the last decade does not, we require to open up. So I often ask my students to de-learn a little bit what they've learned before. And I guess there are real opportunities in that regard.
Thank you, Remco. Colette.
How much time do we have, Moira? You're muted.
3 minutes, maybe?
Yep. Okay. Clearly, I think there have been opportunities in selective approaches in school-based things with work on endemic disease treatment, with nutrition, with mental health. And I think that doesn't discourage me, because I think that when you've got two groups that work in silos, and my organizational theory says they're working in different organizational fields and they have different culture. If you want them to start working together, you don't give them a big comprehensive project. You say, go play around with this little thing over here to start with. And so I think I'm not discouraged by that. I know that the small successes that came out of child survival inspired other selective, larger approaches, and some discussions of more comprehensive approaches within the field of health. To what extent we can take that across two organizational fields that with different cultures, I'm not sure, but I think we should keep going. And I'm encouraged by the continued collaboration on selective stuff. I think that given the bias of education research to US institutions, and the largest collection of education researchers being in the US, and many others in other countries having been trained in the US, there is going to continue to be there's going to continue to be more openness to bottom-up solutions within education than there may be in health. And that between the agency bias of all these American individualists and their allergy to structural solutions, or their insistence to show me where you've been able to do these big structural things and then I'll do something. I think that difficulty working on high-level structural stuff with health is going to continue. And the health people are going to continue to want to do a more there's going to be a more consistent approach to comprehensive approaches, structural approaches in health than there will be in education. I hope that, again, around the SDGs, the understanding that it is the next generation that will carry this forward, and without a social and emotional commitment to the SDGs, and that is most likely, the place for that to happen is most likely in schooling, that is not going to be sustained. And so all of those things, I hope, can be, as people see how hard it is to work from one generation to another, and that children are the place to begin with many of this. I think with many of these concepts, I think that's another area where we can see some productive work. The SDGs must be, and particularly SDG 4.7, which talks about many of the things which will introduce SDG ideas into schooling, are really key. And I think that's where I would see hope. Yeah.
Thank you very much, Colette. And now I will hand over to Tamam, the Managing Director of the Global Health Center, to moderate the question and answer with the audience. Tamam.
Thank you very much, Moira. I'm handed the task of dealing with a very engaged audience in the next 18 minutes. So I will try my best, but I will start with a question that Gita has put forward, and that I think is extremely relevant, but I will expand it if I may. Gita talks about if there's an issue with the democratization of expertise that has taken place in education that hasn't taken place in health. And I think Remco has touched on that as well, in the sense of health professionals are still very rigidly defined, and attempts to sort of community health workers, for example, are very restricted and limited. So for the positive side of that question, do you see a point where, and I'll ask Remco on, whether there is a serious possibility of sort of breaking out from that rigidity of the definition of the healer, the doctor, the nurse, the so on, that is now very training-based, Western biomedicine-based, and has very little to do with anything else?
Yeah, this is a very relevant question. It goes back to work by Ivan Illich on limits to medicine and who controls what's health and not in societies, and how do we define it. And it's, yes, it's, there would be opportunities to do so, but to constitute health interventions and approaches and the governance around it that are democratic, it requires time to do that. First, to deliberate on the underlying values and principles and priorities where people work on, and who should participate and who not. That's a real global health governance discussion that's very vivid now, also with COVID-19. And one thing where it could start with education is principles, education philosophy principles, or political philosophy principles on the social contract, and what is our position in society, and what's the role of professionals, and how do we work on reproductive health matters with informal healthcare workers or with community members that are also having a role in this. And this fora is something that that could be constructed, but it starts with education in the medical field itself, because this is not at all included, because so much focus is now on evidence-based data generation, and that defines this focus, this rather narrow focus on a rather technical data-driven solution, puts a little bit that puts the democratic question aside. So we need to claim space for that, I would say, in medical education.
Thank you, Remco. I will move rapidly just because we have very little time. I think Mara asked a very relevant question. In emergencies in 2016, the expenditure on education was about 2% of the full expenditure. So I'll give you my gut reaction as a medical person who has worked in emergencies all my career. The immediate answer is we have stuff to buy in medicine. You have consumables, you know, and I will go about that to Colette and to Paul, because Paul, you've mentioned the neoliberal, you know, aspect of it, but we in medicine we have another issue, which is a production of physical products that are required for, and I fully understand, like, training is costly and schools and the equipment of them, but we have vaccines that can, you know, you have a course of treatment that costs $100 can be sold for $10,000. There's a corporate takeover of health that is extremely difficult to address. Is that a relevant thing that we can actually cross with education and learn something about? Because we are, COVID-19, if it tells us anything, our conversation has been reduced to prices of vaccines and distribution of vaccines and the availability of, you know, ventilators before that. So I'll ask Paul and I'll ask Colette if you have a point to tell us on how health might be able to use some education concepts to address the issue of this trap we're in.
Yeah, I think, you know, all I can really offer is cautionary tales rather than solutions here. But I think that what you've described does feed into how people describe health and all policies or equity initiatives. They essentially support two different things at the same time. One is a commitment to some kind of preventive work, you know, so in some of the best case countries, you know, like South Australia is often seen as a best case, there will be this high level strategic commitment to preventive health and to get beyond, you know, funding healthcare. But at the same time, there will still be a commitment to funding healthcare, and they go on parallel tracks. And the difference is the health preventive type work gets a tiny proportion of the budget, and the healthcare and reactive stuff gets a huge proportion. And in a pinch, if there is a crisis, then, you know, the preventive work will help pay for the reactive work. And so I think the only thing I could say in terms of a cautionary tale is these things will happen even when people are making a high level rhetorical commitment to prevention and health equity and such like. They never really say, we prevent health equity and preventive type work, but in a really small way. You know, they leave out the small print. So I think the only cautionary tale is to look out for, you know, beyond that kind of rhetoric and look for ways in which people translate that commitment into taking money from healthcare resources to fund it. And I think in almost all studies I've seen, no government or, you know, advocate has found a way to take a non-trivial or non-incremental amount of resources away from healthcare to pay for preventive type work. Essentially, their hope is to build up incrementally from rises in budgets every year. You know, more and more would go to preventive work if the budget kept rising. But any study I've seen suggested that every so often there's a crisis that then takes that money away again. I don't think that I've seen particular lessons from education to get over that kind of work. You know, I think there might be different sectors, but I think most, you know, education type money is spent on schools and staff, and it's very difficult to find, you know, anything except at the margins.
Thank you. Colette, would you like to please?
I'll try to be brief, but it's hard because this is precisely what, you know, the struggle from Health for All in 1978 was about. It was about the fact that the head of WHO at that time had been working on TB in India, and they came up with discovering that if you directly delivered it to people in the villages, you got much better results for TB control than if you took them to a hospital. So he went to the government of India and said, you know, I want you to close the hospitals and put all the money into this directly observed therapy. You know, we're going to send out, you know, barefoot doctors to go take this to people individually, and they're going to comply, and we're going to get much better results. And they said, are you out of your mind? You know, we get money for hospitals. We can't do that. You know, this is a symbol of modernity. This is a symbol of us being, you know, advanced. And so this tension has, the goal of, I was just looking this up, the goal of what Mala was looking for was primary healthcare comes out of villages at reasonable cost, the whole where there is no doctor. For the same reason that we have had a really hard time getting away from this conventional schooling model, however badly it works in emergencies, however badly it works for poor children, however badly it works for kids who are not mainstream and middle class and above, we've had a terrible time trying to break away from those conventional expensive schools and do community schools, which are much more effective in many areas, community-based schools with paraprofessionals. In the same way, the health sector struggles with this Western science issue of, you know, do we send out people barefoot who have very effective preventive stuff and can do most healthcare at the village level, or do we build these hospitals that are symbols of our advanced science and whatever? And the hospitals keep winning, and the schools keep winning. But there are lots of good examples there. And And one of the questions I saw earlier on in the chat, relates to this community-based school thing, and certainly something I worked on for decades, and it's an uphill battle.
Thank you very much, Colette. If I may add, because I've worked a lot of my career on the decentralizing of healthcare, in what I didn't recognize then, and I see more clearly now, is even when it was more of a cost-cutting measure, because it hasn't changed the approach to biomedical. So, for example, a lot of community-based care for children didn't go outside the epistemic framework of biomedicine. It just made it bad biomedicine by prescribing, for example, a single basic antibiotic for almost every infection possible, by reducing diagnostic to dumbed down criteria. It didn't go and say, how do we actually offer circumstances in which diseases do not happen? And this is another curse of the medical care, is that you can reduce it to metrics only without any context, like mortality rates, for example, in children.
Blame it on world culture, not on your health sector. Your health sector is not any more distorted than the education sector is, believe me.
So to continue the questions, I think Hamida had a question that I couldn't read well in the chat, because I think Hamida, you were typing on your phone while listening. So if Hamida is happy to ask her question immediately, if she's still here, I'm not entirely sure. Anyhow, if Hamida is still here,
I think, sorry, if I may, just she did then specify afterwards, she wanted to ask a question specifically about health education in Africa. The second part of her question was about health education in Africa and how it is that this discussion could support that.
She's online, Moira, since she's tried to speak before. Can I take her question directly? I think you're muted, Hamida. Muted still.
Now it should work, Hamida, please.
Oh, sorry. Yes, we have to.
Yes, the microphone. Good afternoon. I am from Algeria, and I want to ask a question. It's very important, the theme for today. Last month, in 6 October, we have discussed about COVID-19, and today about health education, si je peux parler en français, sur le but du développement rural. C'est le quatrième.
I'd like to say that we've been discussing about rural development now. You have actually been referring to health or world education, but what about Africa? The speaker switches to English.
Like Libya, like Egypt. What about Africa? For a lot of problems we meet for education.
Thank you, Hamida. I'll carry it forward. Is there a comment? Do we have, obviously, those of us who have been engaged in beyond our own borders they understand the specificity both of Africa and sub-Saharan Africa. Is there a comment that Paul, Colette, or Remco would like to give us on a specific? What specificity do we have to keep in mind when we address that the continent?
Maybe this is also, but I can reflect on that, has to do with epistemics and working, and this returns also to the notion of colonization and how education and health are still rooted in very colonial practices that require some notion of including different forms of knowledge and values that are being taught in schools and that are being taught for health professionals as well. And too often, and I work with, as an Institute of Tropical Medicine, we work in quite close collaboration with a range of sub-Saharan African countries, and where we see that it's a very rather rigid education and medical model which is still pushed through. And rather than, I mean, the innovation there is we simply need to learn from our colleagues what type of knowledge actually would make sense also to increase people's awareness and skills to deal with health problems. And someone like Seya Abimbola, the editor in chief from BMJ Global Health, talks a lot about decoloniality in this field. So there is attention beyond it, but I think it would require for us Western experts, so to say, also to give space it's about introducing, allowing new epistemics away from the Western ones that are so prevailing at the moment.
Thank you. I'm afraid that we have only a couple of minutes left, and I want to acknowledge the many questions and comments that have been on the chat and that we will not be able to address, and acknowledge my inability to have collated them better. But I think we have the customary 30 seconds of each of the speakers. If you'd like to give us the last nugget of wisdom before you leave us for the evening. Thank you. So I'll start with Paul, if you may.
Oh, thank you. I mean, all I had left to say, I guess in terms of the questions, it is interesting if you look at the the reviews we did were on published research articles, and so very much the vast majority are of a small number of Western countries. So I think that is an issue that's come up here, that most of the lessons that are published in these fields are from a very small number. So in health, almost half of them were from Nordic countries and Australia, and in education, about 2/5 were from the US. So I think that would be one of the things that we bear in mind. The lessons you would take from these experiences may not or will not be transferable. And I think that might be the context for modern discussions of decolonization. They're from quite a low base. I think there's a history, and particularly of health, of seeing non-Western countries as a problem to be solved rather than a collaboration to be done. And I think it'd be the same often with education. There may be a focus on decolonizing education in certain countries, but at the same time there are huge pressures to follow global agendas that would undermine that process. And these things go on at the same time.
Much appreciated. Thank you, Paul. Colette?
One of the areas where education envies health is that they have been able to establish in several sectors, they've been able to establish over many decades real research centers focused on specific issues in the 2/3 world. And there is not a lot of relevant education research coming out of the 2/3 world that can be used to beat funders over the head to get money for different projects. And instead, we find in much of Africa and in North Africa that they're very much tied into this conventional schooling approach that doesn't serve a lot of children. So health has been able to come up with innovations that it then has scientific research for, that then they're able to get funding to do different things and to experiment and to come up with some selective approaches, not comprehensive, but selective, that do something a little different. But for much of the 2/3 world, we don't have education research that would provide that sort of data. And so the research agenda driven by international agencies and the first world, and that does not produce things that are necessarily as useful in North Africa and Africa, Hamida. That would be my answer to you.
Thank you, Colette. Remco, would you like a last word, please?
Yeah, a message of hope, because we're going through very transformative times at the moment, and that also means that communities, peoples are starting to learn that one needs to work in a more networked way. There's a lot of things to that have been developed in Western education and healthcare systems that can be maintained, but the ownership of that and to allow new forms of knowledge and understanding of what is needed in different contexts and times ahead, I do see that there's space for that. But once again, that space should be allowed. So we really need to think about other models away from the old neoliberal individual-driven models that we've been using for the last decades. But that's where I really see possibilities at the moment.
Thank you, Remco. What I envy about education is you seem to have a very engaged audience in your events, people that actually are on the point. But more seriously, coming from a medical background, what I envy is the existence of an inspiring emancipatory discourse on how education can be part of that emancipation of people. It addresses its subjects. I don't think we're there yet in health. And even if it's difficult to fund and difficult to address, I wish we had that more developed in our context and have it more imprinted in people's mind rather than their medical textbooks being the only guide to how they deal with their professions and lives. I'll thank you very much for the incredibly useful experience, and I will hand back to Moira and Daniela if you want to say anything before we close. Thank you very much.
Thank you very much, Tamam, for that. And an enormous thank you also to our three speakers, Paul Kearney, Colette Chabot, and Remco van den Pas. Daniela is going to put an event survey into the chat now. We'd be very grateful if you would fill that in and let us know how we can improve on what we have done today. Also, for those of you who are interested in the decolonization question, I've just put in a link to a recent issue from the Graduate Institute addressing decolonization. There is one piece on health and one piece on education, as well as many other issues to be considered. And I think Paul asked the question at the end of his presentation, does anyone want these lessons on intersectoriality? And I think there's no question at all that the audience today has very much wanted them. And the idea is, I think, that we have left people wanting to hear more about this and to think more deeply about it and to think in more decolonial and geographically specific ways as well. So thank you to everyone for coming. Thank you very much to our speakers. Thank you to the Global Health Center at the Graduate Institute. Merci beaucoup aux interprètes. And thank you to Elisa and Daniela for all of their support in the event. And do take a look in the chat for some upcoming events that may also be of interest to you. Thank you all so much. Good night and good afternoon and good morning, wherever you are.